Hey guys, so today we will be welcome back. So today we will be talking about the drugs on asthma. So I'm not gonna go really deep into the drugs, but I'll be talking about which not really drugs, but I'll be talking about which inhalers or which tablets should you take when depending on what severity of asthma attack that you have. So, this video is made in belief that you know roughly what are the inhalers that I'm gonna talk about. I'm not gonna go really deep into the those medications. Okay, so I'm just going to teach you how I'm just going to tell you how what inhalers I'm just going to guide you on what inhalers should we seek for depending on the type of the severity of the asthma attacks. Okay, so as for the introduction, okay, before I start anything, I should give the credits of this lecture to the sign guidelines for because I'm just gonna follow what they have stated in part of their guidelines, as well as credits also goes to Miss Sharon. I've learned a lot from her. She's a clinical lecturer from Newman, Industrial Ministry Medicine Lecture. And also I would like to um, give credits to Rang and Dell Pharmacology because yeah, because I'm just going to talk like briefly about those medications effects and all. So yeah, Rang and Dell have helped me a lot in order to understand those things, and I'm just gonna deliver a few stuffs from it in this video. So before I start, this okay, let me just give an introduction for this video. So basically, you should know that all people with asthma or anyone their parents, or the kids, the parents or the carers, all of them, the patients itself, the patient usually asthma attack will actually starts in the early childhood. So we will usually like talking together with the kid, or and we also should include the parents or as well as the carers, and all of them should be offered a self-management education, including written personalized asthma action plan. So usually it is supported by a regular professional review, and it is basically important to remember that managing any chronic condition requires the patient to understand their condition and the logic and the rationale behind the treatment. So then only they would actually know what is going on wrong, and they would eventually adhere to the medication and all the um, guidelines that are advised to them. So because they are the one who deal with it 24/7. It's not the doctors. The doctors possibly would just like interact with them a few hours per year. So since they are the one who are handling with this, they should know what is going on wrong. So when the doctors, okay, when we GP, when we are actually giving those action plans and guidelines and all those stuff, we must avoid judgmental biases on their adherence as well as compliance. So we must always seek to understand the patient's perspective. Like sometimes they would think that why is this happening to them? This is unfair, and the life is unfair for them. We should make them understand that this is a condition which uh, which is easy to manage and that they can do it. So usually the possible cause of non-compliance would be because of due to the side effect, or probably they are forgetful. Okay, forgetfulness is something that we cannot avoid, or maybe of financial concern, they cannot afford for the medication, or even if they fail to understand the chronicity of the disease, they also could go to not adhere to the medication. So we as GP, we should be responsible to make them understand about their condition, especially this asthmatics. Okay, so now I'm gonna talk about the aims of the treatment. Like every treatment for any disease would have an objective for itself. If not one, they have a few. So I'm just going to talk about the treatments of the aims of the treatment for the asthma. So asthma is something not curable, but it is something that we can always manage it. Like we want to always because usually asthma is usually caused by genetic condition. It's usually atopic means you usually have a predisposition to a certain condition. So basically um, you can't really cure it from like you cannot cure it permanently. You can always control the symptoms by first of all preventing the triggers, and second we also can prevent the when we prevent the triggers we can eventually prevent the attack. So it's a indirect form of curing, but it's not something that is permanent. Okay, so it all depends on the effort of the patient itself. So the complete control of the treatment is defined as the usually okay, when we say that the patient does not have symptoms, or when the patient is having a complete control of their asthma attack, we say that the patient does not have any daytime symptoms, they don't have any nighttime awakening due to asthma, they also no need for they don't have the need for rescue medication, the inhaler, the blue inhaler. They also don't have any asthma attacks. This is the main one. And they also don't have any limitations on their activity, which means they can actually do any activity without any need of the inhalers. And they also have a normal lung function, which is more than 80% predicted FEV and or PEFR, and also they also have a minimal medication side effects. So now I'll be talking about a certain clinical drug usage abbreviation. All these things you be coming across when you're actually studying pharmacology in bit more detail later on. So usually sometimes you can see in the tablet package that the nurse would have written BD. BD means twice a day. That means you should take the drug twice a day. TDS means thrice a day, 3 times a day, and PRN means per required or per needed. Okay, so now I'll be talking about certain drugs first before I go on to the ladder technique, how to use this ladder technique when you are actually prescribing medications or inhalers for the asthmatic patients. So the first drug that I'm going to talk about is the short-acting beta-2 agonist, also known as salbutamol. So basically, it is an acute bronchodilator effect. It has an acute bronchodilator effect. Usually, it has an onset of 5 to 30 minutes, and it can actually give you relief for about 4 to 6 hours. And usually, it protects against various challenges. For example, when you're actually having cool air, when you're actually exposed to cool air when you're doing exercise. All these people are actually um, these are called also known as an intrinsic asthma attack, which means there is nothing from outside that is causing the asthma. That is something from inside that is causing the asthma. So it's called exercise. If there is something from outside that is causing the asthma, that is called extrinsic asthma attacks. This is the most common type of asthma attacks. Usually it is, for example, allergies to dust, pollen, and rye, or all those stuff. So this drug salbutamol is actually usually would be the agent of choice for acute asthma. Usually it would be blue color, and in the pharmacy you can get it in the brand name of Ventolin. And since we are actually giving it via inhalation, the side effects is greatly minimized. Okay, then we also have this thing called as the I'm sorry. So we also, that is for server. So the next one, we also have this thing called as the LABA. So LABA is also known as a salmeterol. So It is okay. The abbreviation for LABA is a long-acting beta-2 agonist. So they are actually chemical analogs of salbutamol, but they usually would have a long lipophilic side chain, which anchors the drug into the lipid membrane. So this actually allows the active portion of the molecule to remain at the receptor site for a longer period of time. So they can actually usually continually they can bind and release their active sites, so which this causes the drug to have a longer period of effect, but usually they don't cause. When you have an acute asthma attack, you don't use this, you will always use SABA, not LABA, because you want an acute, you want an immediate relief action. So this LABA actually provides bronchodilation for at least 12 hours. But they are usually, as I said before, they usually would have a slow onset, so they should not be used for a relief of an acute asthmatics. So the common side effects of both LABA and SABA are usually they don't have any side effects at normal dose. Only when you are actually having a severe type of asthma where you have to increase the dosage, then you might have these side effects such as tachycardia, hyperglycemic, as well as skeletal muscle tremors, because basically they're actually activating the sympathetic pathway, which actually eventually cause all these things to actually happen. The next drug that I'm going to talk about is the next drug I'm going to talk about is a muscarinic antagonist. Yeah, for example, such as ipratropium and tiotropium. So they are usually alternative or addition type of drugs. That's why they are known as a second line of drugs. They usually competitively antagonize the effects of the endogenous acetylcholine at the M3 receptors. As we know, the bronchial smooth muscle, we actually have this M3 receptors, and when there is a release of the acetylcholine onto those smooth muscle receptors, it will eventually relax those bronchial smooth muscle. So when I mean, as in when the acetylcholine is actually blocked from binding onto the M3 receptor, the parasympathetic pathway is not activated. So eventually, the bronchial smooth muscle will undergo relaxation, and it will also will decrease the mucus secretion. So they usually don't have any effect on the late phase. And at the same time, this is an important point to note that they are not traditionally effective in asthma unless COPD is also present. So usually LABA is usually present in is usually prescribed in COPD patients or asthma with simultaneous COPD events. So at the same time, they are also useful in patients who are unable to tolerate adrenergic agonists. For example, when the patient is having ischemic heart disease or tachycardia, we usually don't want to prescribe them the beta-2 agonists, because those things will actually increase the heart rate, increase the heart activity, eventually can cause some heart problems in those who already have some heart problems, make things more worse. So this is the second type of drug that I'm going to talk that I have talked about. The third type of drug that I'm going to talk about is um, okay. Uh, Usually the okay I want to talk about the side effects of the muscarinic antagonist. So when we have this muscarinic antagonist, it means they will actually have this anticholinergic side effects, for example dry mouth, constipation, nausea, and these are the reasons why patients might stop these medications, because these symptoms are actually quite common in those who are taking these medications. So this is why, yeah, they might stop the medications. So then I'll be talking about uh, another medication which is a corticosteroid. For example, we have a beclomethasone, which is inhaled, prednisolone, which is given in oral form, and hydrocortisone, which is given in IV form. So these corticosteroids are actually very, very, very important. They will actually prevent corticosteroid, as we all know, it is usually used in the prevention of the inflammation. Okay, so asthma, as we all know, it is all about inflammation, and we want to prevent inflammation in the airway over the long term. That's why we will actually provide them with the corticosteroid, for example fluticasone. So yeah, I'll
come again with the details of the radiotherapy in the next video.